Right. So I had a similar teaching this morning with group 1. You guys are group 3, right? Or have I got it the other way around?
Yes, yeah, we're group 3.
Okay, group 3, good. So I was thinking doing a kind of a problem-based learning, since we're all doing this at the comfort of our seat and our homes, including myself. And I was told that you're all going to be back at the end of this month, hopefully, if all is well. So we can do a bit more face-to-face teaching. We can concentrate on more face-to-face teaching when you come back. So right now, I think we'll just make use of what we can do, using the technology that we have. So I thought of doing this kind of, more towards going through past questions, and certainly past PMPs, and we can convert that to kind of a problem-based learning. Um, so shall we do that? So I've got one case which we used previously in our end of block. Let me just share that in the WhatsApp group. I'm sorry, it's just going to be a picture of what I snapped earlier from my laptop, because my laptop is too slow, like you would expect. Let me just see, I've got the right one beforehand. Yeah, okay. So if all of you can have a quick look at your WhatsApp kind of group that we set up, there should be the question with the trigger 1 in place. Can you all see?
Yes, Doctor.
Right, okay. So let's just take time reading it. So I'll kind of say again.
Should you share the screen, Doctor?
Yes, by all means, if you want. Okay. Can everyone see it? Can everyone hear me?
Yes.
Yes.
Yes,
Okay.
Doctor.
Right,
So
we cannot see.
you
Do
cannot
you want to
see,
present here, Doctor?
or you want me to share the screen there?
Oh,
Oh,
okay.
okay. Afika is sharing. Okay. So the trigger is a 4-year-old boy presented to the emergency department following a 4-day history of high-grade fever up to 39 degrees. I'm sorry about the quality of the picture. According to that, the fever started abruptly and does not respond to antipyretics and antibiotics given 2 days earlier by the GP. Okay? So we got a 4-year-old boy presented to ED with a 4-day history of high-grade fever. 2 days earlier, they went to see the GP. GP prescribed antibiotics and antipyretics. Upon further questioning, there has been flu-like symptoms for the last 3 days. That denies any sick contact. On physical examination, he had widespread purplish rash. Okay, so this is a typical kind of trigger 1, kind of starting point where we give a little information about the history. So the typical question would be things like, what further questions would you ask, isn't it, about this child? What other part of history would you want to check on this child? Anyone can answer this.
Maybe regarding the pattern of the fever, does the
Yeah,
fever is continuous in terms of the severity, whether it's persistent or
yeah,
not?
good. Okay, so you want to know a little bit about the fever, where there's some progression, whether it's getting more severe, more worse, more frequent. Okay, yeah, so you do all your fever mnemonics in terms of the onset, characteristic, and whatnot. And okay, so including things like relieving and aggravating factors as well, you probably want to put in there. Okay, yeah, so that's one. You want to ask more about the fever. Anything else would you ask about?
I want to ask more, explore more about the flu-like symptoms.
Say again?
I want to explore more about the flu-like symptom, whether there is any
Yeah.
cough,
Mm.
runny nose, sore
Yeah,
throat.
good. So, I mean, that's the other kind of important symptom here. It started off with the flu-like illness. So, yeah, you want to know whether it's just URTI or whether there's actually cough, whether the cough was significant, whether associated with any chest pains or out of shortness of breath. Okay, so you want to ask a bit more about that, yeah? So we now covered a little bit about the fever, a little bit about the flu-like symptoms you want to know about. Going back to the fever, maybe you want to ask, following giving antipyretics and antibiotics, were there any improvement? And I forgot to mention about this. Sounds like, based on this, do you think there was any improvement or not?
No.
Yeah, so it's very typical that parents will seek further help and consultation if the fever doesn't resolve. I mean, fever is usually the bread and butter of pediatrics, isn't it? So fever in a child is very common, and it's usually a marker of well-being. So it's very common that, I haven't seen a GP. If the fever persists, the parents will start to think about, is there something else that's not quite right? Do I need to seek further consultation elsewhere? Sometimes parents will go back to the same GP mentioning, we tried the antibiotics for 2 days, still tak berkesan, so why is my child still got fever? And sometimes the GP will start thinking of referral to the pediatric team, or sometimes the parents might choose to go to emergency department. And the majority of the time, the reason why they end up going to the emergency because normally it's either because the child looks more unwell or whether there's new symptoms, or they might think that the GP was not very good, for example, not like us. Just joking. So so you want to know about why the fever is not settling, isn't it? Okay. What's the next clue here? He's got a rash of some sort. Okay, what do you want to know about this rash?
For the rash, first I want to know the distribution of the rash.
Yeah.
Okay, and then is it blanching or not blanching? Because it just said it's Turkish rash.
Yeah.
And then the association of the rash, is it itchiness, painful?
Yeah.
Okay.
Where the rash started first, and then where it distributed.
Yeah.
It's on.
So you want to know what the distribution of the rash. You want to know about as you said, the nature of rash, whether it's painful or non-painful. So you want to know a little bit more about the character of the rash, isn't it? So what at this moment of time with this rash, fever, flu-like symptoms, anything you would think about straight away in your differential?
Meningococcal.
Rash.
Meningococcal, good. Yeah, so I think that's one of the top ones in the list. As why meningococcal? Based on this slight description, why would you say meningococcal is one of the top? What
Not
in the
responding.
paragraph? What bit in the paragraph that makes you think it that way? Not responding to antibiotics, okay? So that
High
could
grade
be
fever,
one.
bacteremia,
Fever.
Yeah.
bacteria.
Lagi.
The characteristic of the rash, because it's
Yeah. So what about the rash makes you think this could be meningococcal?
this is widespread. So
Yeah.
usually meningococcal it does not have any specific
Good. Yeah.
type
So
of
meningococcal tends to be widespread. Yeah, I agree. And
and
what else about the
the
rash?
purplish
That's
rash.
purplish rash. Yeah. So it's
So it's
purple in color, man.
blanching usually. So
Yeah. So I mean, we don't know whether it's blanching or not. That's
Mhm.
probably one thing you want to you will end up answering in your further questions about physical examination. But the purpose rash suggests it looks more like a bruise type rash, can. So you remember your types of bruise-like rash, which includes things like petechiae, can, ecchymosis, purpura. So you're thinking along those lines, can, usually, if it's kind of purplish rash. So I think with the rash, I think we need to explore further. Most of the time, we can't really appreciate rash by taking a history. It's something we have to observe and examine. Okay. Anything else in relation to your history that you want to do? What are the history that you want to take?
I want to ask about history of pain, such as abdominal pain or abdominal discomfort, and history of whether he was had any episodes of vomiting.
Why do you want to know about abdominal pain? I agree.
Because of the rash, it was presence of abdominal pain, then I would like to have HSP as one of my differentials.
HSP. Yeah, good. I think it's a good differential to use. So for HSP, you want to cover things like if there's any abdominal symptoms. Apart from HSP, the other thing I can think about is dengue as well. Dengue with warning signs might present with, kind of petechia and also with abdominal pain. So I think that's a good line of thinking that you want to exclude abdominal symptoms. Any other symptoms from other organ systems that you might think about?
Any joint pain or swelling?
Good. Thinking of what?
HSP, also related to HSP. And also any abnormality in the urine.
Yeah, good. Such as?
Like hematuria.
Hematuria. So you can get hematuria with HSP. You can get hematuria with PSGN, isn't it? So glomerulonephritis. So it could be that the child had some kind of flu-like illness with fever and sore throat. So maybe you want to know whether there's any sore throat in relation to that as well. Good. Anything else?
I would like to rule out any CNS involvement.
Okay.
Which is patient having seizure or any unconsciousness during the fever, since meningococcal, the most common cause is meningococcal meningitis.
Yeah. So I agree. I think we need to kind of think a little bit more lateral, making sure we do our systematic reviews to making sure because fever in a child, you need to find the source, and sometimes knowing where the source is, you kind of need to go through the systematic review and ask all the organ systems, including CNS for signs like headache, neck stiffness, and as you said, altered consciousness and so on. I think that we can probably assume, I mean, it's difficult to say at this stage, but if there was some CNS signs, I would imagine it would have been quite significant. So it would have been mentioned very early on in the triggers, perhaps, if there was signs of meningitis. But maybe, I think with any query meningococcal, you have to worry about CNS infection. However, do remember, meningococcal septicemia might occur even without CNS involvement, yeah? So you can get meningococcal sepsis even without meningitis. And in fact, that is much more common compared to meningococcal meningitis, which is a lot more rare. But occasionally we do see them together, meningitis and meningococcal septicemia occurring at the same time. So I think it's something important to explore. In terms of physical signs, now what physical signs would you want to look for in cases like this?
So I think first I would like to rule out the emergency left ventricular condition, which is sign of hypoperfusion, because it can cause shock. So sign of hypoperfusion including CRT, capillary time, increase in pulse rate, and also increase in respiratory rate, and also I would check the blood pressure.
Good. If you suspect meningococcal sepsis, so septicemia, how soon do you think the child will deteriorate? Like over a matter of weeks, days, or hours? Which one would you choose? How quick is meningococcal septicemia once they start to be infected to the point of needing ICU admission and intubation? Days, weeks,
Maybe
or hours?
I'm not sure, but there is a
Sure.
rapid progression that we call as fulminant septicemia, but I'm not
Yeah.
sure about the duration.
Yeah, it's actually quite quick. Meningococcal septicemia is one of the quickest infection that can deteriorate and that can spread very easily. Okay, so we're looking at a matter of hours or less than a day since the fever started. So I think why it's important to check the hydration, the vital signs. Always start with your ABCs first, as usual. So look for signs of dehydration, signs of shock, especially if you think this is sepsis. Then obviously you want to check your blood pressure, heart rate, and capillary refill time, as you mentioned earlier. So yes, it's important. The fact that the fever started for 4 days make me less think of it, but I will come back to that in later on. Okay, so any other symptoms or signs you want to look for?
Sign of meningitis.
Meningism, good. So again, CNS infection. So what test would you do for that?
Kernig sign and Brzezinski.
Kernig and Brzezinski's, yeah. So it's good practice to always perform that whenever you suspect CNS involvement. It can be a bit tricky to do it on a child who is very small because it's difficult to appreciate whether when we maneuver their neck or leg, whether they cry because of us just doing it or whether it's because of pain. In order for it to be positive, then normally it involves pain and irritation. So the movement that you want to elicit, for example, in Kernig's is the legs drawing up, and Brzezinski's that the neck is flexing forward, is much more useful in older children. Younger children, it can be misinterpreted because of the tolerance. Okay, but yeah, okay. What else would you do? What other signs would you want to look for?
So,
what about signs of dehydration, such as reduced skin perfusion?
Yeah.
Or if the baby has crying without tears, or 4 years old.
Yeah, I agree. Yeah. Okay, so you want to check for signs of dehydration. It's very common that if they've been unwell for a few days, they wouldn't be able to eat and drink properly. Okay. Anything else?
Check for the oral hygiene of this patient. Maybe have any inflamed tonsils.
Okay, good. So we've mentioned earlier about history of sore throat. You want to do ENT examination. So you want to look at the tonsils because what the differential could this be? Fever, rash,
Measles.
Measles, yeah. Okay, I would probably. I mean, we don't see that a lot these days because of vaccination, but we do see it more. So I think measles is important, especially the widespread rash. What's the typical pattern of rash in measles? It starts where? Measles start off?
Face.
Yeah, it's actually truncal. It starts from the trunk first, isn't it? Face, and it moves on to your peripheries. So it has this kind of ascending pattern to it. But if you look at the throat, then what's the pathognomonic sign of measles? What would you see in the mouth? The pathognomonic sign. If you see this, it's measles until proven. Yeah, cochlear spots. So these are like very small white spots that's kind of widespread in the mouth. This is pathognomonic for measles, we were told. Whether we, we see it often, certainly not. But I think you cannot rule out things like scarlet fever as well, isn't it? So if there's a pus in the tonsils indicating could be streptococcal infection, then you would want to check for that. Okay, so yeah, so I think someone mentioned earlier about joint involvement. I think that's important as well to look for. In case this could be things like, again, scarlet fever or Kawasaki and whatnot. I think that's certainly something to explore. Or rheumatic fever, yeah. So I think there's a lot of possibilities here. So let's just, I'll just share the next trigger, shall I? 2 seconds. Let me just,
Yes.
for you. Okay, so it should be in the group. So the next trigger involves a picture and some vital signs. Okay, so the child was admitted to the pediatric ward for further observation. His vital signs. Can you all see?
Yes, doctor.
So heart rate is 132. 2 seconds. So heart rate 132. Respiratory is 24. Blood pressure is a bit on the low side. 96/60. That can be, is this a 4-year-old child, isn't it? So I think that's acceptable, maybe slightly on the low side. And then we have a temperature of 38.9, so 38.6. So he appears extremely irritable. He has multiple mucosal ulceration around his mouth, as you can see in the picture, and along with bilateral conjunctivitis. Yeah? Okay. So, what do you think about the vital signs?
Tachycardic and hypotensive.
Yeah, so I think a bit tachycardic. I wouldn't say a lot, and certainly a little hypotensive. Certainly, I wouldn't say it's shock. So that's kind of telling me that this we're probably not looking at a meningococcal septicemia type problem, because if it was, I would expect the blood pressure to be a lot lower, and I would expect the heart rate to be a lot more higher as well. So actually, the cardiovascular component is not that really worrying in a sense. What does worry me is obviously the picture, isn't it? So what can you see in the picture?
Inflammation over the mucosa, such as the lip.
Yeah.
Could be like Stevens-Johnson syndrome.
Yeah. Okay. So I mean, there's a lot of mucosal involvement here, mucosal inflammation because it's swollen. You get bleeding that's indicating breakdown of tissues. So what you can call this mucositis, if you want to give it a name. We cannot quite appreciate the tongue. Is the other thing you want to look if it's kind of strawberry colored, whether it's inflamed as well. I don't think we can quite appreciate the conjunctivitis, but according to the history, this child has bilateral conjunctivitis as well. Okay, so with that picture in mind, along with the first trigger, what would be your narrower differential at this stage?
I'm thinking of Kawasaki disease, since patient have fever at least. It fits the criteria of the cream fever, and also have conjunctivitis and mucosal involvement.
Yeah.
And also the rash.
Yeah, so I mean, rash we've not seen, but certainly widespread. rash. What's the typical rash in Kawasaki?
Sorry, doctor?
What is the typical characteristic rash in Kawasaki? Do you know?
It's maculopapular.
Yeah, so it's maculopapular and
multiforme.
multiforme. Okay, it's actually polymorphous, isn't it? Yeah, polymorphous rash. So it has different morphologies. So some of them are like small red pinpoint rash. Some of them are bigger, but generally described as maculopapular type. Okay, rather than say again.
I just want to ask if you want to consider Kawasaki, is it the fever does not meet the criteria for
Kawasaki? I think the fever is a little bit too early. You're quite right. It should be 5 days rather than 4. But I think it's always good practice to always think in advance because you know that this child's already had fever 4 days. Tomorrow, most likely, he might still have fever, isn't it? So it's sometimes, yes, Kawasaki, that is the required criteria, not even major or minor. You need to have fever for a minimum of 5 days. But you can start thinking about it, perhaps even before you reach that criteria. Most of the time, you will end up maybe treating the child for something else first, such as streptococcal infection, in case, like, for example, scarlet fever. So normally we do start them antibiotics. But we know that in Kawasaki, even if you give antibiotics, it doesn't resolve. Yeah, so I think Kawasaki is a possibility in this situation. Okay.
Doctor?
Yeah, go on.
Can I consider Stevens-Johnson syndrome or toxic epidermal necrolysis since
I think so.
The patient has history of taking antibiotics?
Yes, correct. Well done. So I think Stevens-Johnson certainly is on one of the top differentials because of history of taking medicine, isn't it? So in particular antibiotics. Yeah, I mean, we don't know which antibiotic in particular this child took, but certainly is one of the precursor. But do bear in mind that not only medication triggers Stevens-Johnson, even any viral infection can trigger SJS. Yeah, things like your usual influenza, adenovirus, enterovirus, and also mycoplasma. So any infection can actually trigger Stevens-Johnson syndrome. So to sometimes pinpoint it to one trigger is impossible. There are certain triggers that are notorious to cause Stevens-Johnson, such as aspirin. So that's why we don't like aspirin in children because of all the risk factor that it can cause or all the side effects it can cause. Okay, so I think the possibility here, could this be Kawasaki or evolving Kawasaki? Could this be Stevens-Johnson's or scarlet fever, or it could just be a simple viral infection? With that in mind, what investigations would you want to perform at this stage? Can you think of any investigations you want to do?
First, I would like to do full blood count. To see any evidence of leukocytosis and to see the numbers of neutrophil and lymphocyte to demonstrate whether it is a bacteria or maybe viral. And also I want to see the platelet level of this patient since patient has a rash. And that's among the investigation I'd like to do.
So tell me about platelets in Kawasaki. What do you see in terms of what is the expected result in someone with Kawasaki?
Thrombocytopenia?
Yeah, it's actually thrombocytosis. Yeah, so elevated platelets. But it's not quite a useful sign during the acute phase because the timing for the platelets to rise can take a while. So it can take a matter of a few days once the illness has started before you see the thrombocytosis. So I wouldn't say it's a specific sign that can be helpful in the early stages of the disease. Okay, good. Any other investigations you would want to do?
I would like to do a blood CNS.
Yeah, okay.
Okay.
It's always a
Since
good
this patient,
practice to send cultures, yeah. Because the 1 hour differential earlier was what?
meningococcal septicemia.
Yeah, so meningococcal. So meningococcal is very easy to culture. So you expect to get the results within a few hours sometimes because you can see the gram positive organism even under microscope. So it's one of those things that you should send even if you think this is Kawasaki, this is if you think it's not infection. But I think infection still should always be in the on the cards. And so you have to send culture. Yeah. Any other tests?
I would like to send for inflammatory markers such as ESR or CRP.
Yeah, okay. I think so. What is the latest infection marker that is getting more kind of popular these days? Do you know?
CRP and ESR.
Yeah, so procalcitonin. Yeah, I've heard someone mention that. So procalcitonin seems to be a much better and specific marker of infection, even better than CRP. And the thing about procalcitonin, it rises very early in the early stages of the disease. Unlike CRP and white cells, they can take time to build up, but procalcitonin is one of those that rise, one of the first to rise. So if you do it early, it might give you a clue that this is infection that you're dealing with. So it is expensive. So hopefully, in the future, so that would be a useful test to do to delineate whether it is infection or non-infection. Okay. Any yeah.
Doctor, does the procalcitonin also can be used to monitor the progression after we treat the patient?
Yeah, I think you can use it as you would with CRP as a monitoring of improvement. Yeah, so but maybe because of how expensive it is at the moment of time, we wouldn't do it on a daily basis. For example, maybe you do it after you complete the treatment and you want to consider stopping antibiotics. You do one more procalcitonin down the line to see if the markers are back to normal. So yeah, but I wouldn't say it as a monitoring tool that you're able to do at a daily basis at this point of time yet. But it's a very useful test to have, and I think ICU use it quite a lot. In cases where they don't know infection, that making the point is a very useful marker. And the thing about procalcitonin, if you do it early, it can actually start even before symptoms appear sometimes. So that's how useful that sometimes you can preempt an impending sepsis even before the patient goes into shock and whatnot. Okay, so there are many clinical utility that we can use for with procalcitonin. Okay, any other tests would you perform? Is there any test for Steven Johnson?
Skin biopsy.
Yeah, so unfortunately, there's no kind of bedside test you can do, but skin biopsy is the only clue to actually give you diagnosis definitively. However, most of the time we diagnose Steven Johnson's clinically, isn't it? So so because skin biopsy is not freely available, you need expertise and you need a lab to able to run the biopsy for you. But in literatures, that's what you want to look at. Okay, so let's look at trigger 3.
Lotfi,
Yes, go on.
should we also send coagulation profile for this patient?
I think so. For any child you suspect any bleeding or bruising, I think always do clotting. Yeah, I think we've not mentioned that. It's always an important test for me. And also electrolytes, just in view of hydration status, renal function, I think is useful. Some people might put things like in other tests like ASOT. So ASOT or Mycoplasma titers. Mycoplasma is the other infection that everyone always seems to have kind of confusion about, because Mycoplasma can present in any shape and form, like dengue as well. So dengue can also be a mystery to many of us, because they can present differently for every different person that walks through the ED department. So sometimes when we're not sure, it's always useful to check Mycoplasma and dengue serology as well. Okay, let me share the last trigger.
Doctor, sorry.
Yes, go on. Yes.
And can we consider toxic shock syndrome for this patient?
Toxic shock syndrome as in staphylococcal skin syndrome? Toxic shock syndrome as in, yeah. So toxic shock syndrome, I think is a fairly good differential. And normally we see it as a complication of staphylococcal infection. The only thing that's kind of against this being toxic shock syndrome is because there's no signs of shock in the child. But obviously that can change in the next few hours. I think it's a useful thought. Normally you expect the child to have some degree of either skin infection or some kind of pneumonia type infections that are staphylococcal related. But again, there is no clinically, there's no way you can know unless you culture, and if it turns out to be staphylococcus, then that's when we probably think about it. Most of the time, we would have started on patients like this on broad spectrum antibiotics. That would cover both strep and staphylococcal, just so that we already started the ball rolling, just in case that it turned out to be staph infection. The antibiotics already started before. So that's how we kind of cover all angles when dealing with situations like this, where it can be either both infectious or non-infectious. And even non-infectious can be either Kawasaki, Stevens-Johnson's, and toxic shock syndrome if it's just the toxins that's causing the problem. Yeah. Any questions? That's a good one. Anyone else want to ask anything? Yeah, okay, so let's look at trigger 3. So this is the investigation results that we have asked for. So if you can look at it, so basically the HB is 9.9. White cells is actually pretty normal, 11.4. Platelets is not very low, or in fact it looks normal at 240. ASOT is negative, CRP is slightly raised, including ESR. ESR is raised as well. Normal should be less than 5, but the Mycoplasma titers is positive in this context. So what do you think is the diagnosis? Have we reached a diagnosis, you think, based on the investigations?
Yes, doctor. I think yes, doctor. Since we got a Mycoplasma titer positive, and then a little bit raised in the WBC, and also CRP and ASR also indicate there is an inflammation infection going on. Then I think, and then this patient also previously had is it flu-like symptoms?
Correct.
I think it's could be a typical pneumonia.
Yeah, okay. So I mean, the thing we don't have is the chest X-ray and also the chest findings. So we cannot say for sure it's pneumonia. based on that alone. But it sounds like this child has got a proven Mycoplasma infection here, isn't it? And this is what I'm saying about Mycoplasma. It can present in many ways, not only pneumonia type, it can also present with extra, respiratory manifestations. The fact that the full blood count is not very surprising. It looks pretty normal, isn't it? So we're probably not dealing with severe infection here. I mean, you would say the CRP is high, but not terribly high. We're not looking at hundreds in cases of severe infection. The ASASOT titers are negative, so we know this is not streptococcal. But the ESR is the one that's really elevated here, and that's showing, telling us there are signs of inflammation going on. Okay, so with a positive Mycoplasma, but not so severe infection from the white cell count and CRP counts, but significant signs of inflammation, what would you put down as your top diagnosis based on the picture we saw, based on the initial triggers that we've read? What could wrap all this into a nice fitting diagnosis?
Stephen
Okay,
Johnson.
Yeah, so I agree. So the Stevens-Johnson syndrome, perhaps secondary to Mycoplasma. Yeah, so that's what I would put down here. Yeah, so if some people might just put down Mycoplasma infection, but the key thing here is sometimes we have to think it cannot be that straightforward, isn't it? Yeah. So if we put down what is the full diagnosis? You put down Mycoplasma. That's given already in the triggers, isn't it? So do you think you'll get any marks if you answer Mycoplasma alone? Perhaps not. So the reason why is there means there must be something, a unifying diagnosis that might explain the initial triggers and explain the physical examination finding, because Mycoplasma on its own, they don't tend to cause mucositis. Okay, so if you have mucositis with evidence of Mycoplasma, it has to be a complication that has been triggered by the Mycoplasma. Yeah, so when it comes to full diagnosis, I would say Stevens-Johnson syndrome secondary to Mycoplasma infection. Everyone clear about that?
Yes.
Yeah. Okay. So what is Stevens-Johnson syndrome? Can anyone tell me what it's all about? Anyone who wants to have a go? You all have your mobile phones next to you. You can just quickly Google it up and just read it out.
It is a serious reaction of the disorder that involve the skin and also mucous membrane. And usually it is caused by the reaction from the could be a viral infection, drugs, and also antibiotics. So yeah, include antibiotics.
Yep.
That's all that I know.
Okay, good. I think that's a good introduction. Is it a dangerous condition?
Yes. It's emergency.
Can cause
emergency. Can cause heart damage.
Shock.
Okay. It can cause shock. Yeah, depending on how much skin is involved, because you have to think the skin as a very vital organ of maintaining hydration. Yeah, our skin acts as a barrier to keep moisture and fluid in our body intact. The moment if you lose that barrier, if the skin is damaged, then you will lose a lot of fluid. So we might think, things like, you can compare it to a child or a person who suffered burns injury. People die from injury to the skin from burns, especially your second degree and third degree patients, because of excessive fluid loss through the skin. And this is much more dangerous because people don't realize it, isn't it? Because we don't see the water, loss via the skin as you would see in comparing to someone you would see who's vomiting in front of you or not passing urine and so on. So it's often the thing that we don't take seriously. But in the same context of Stevens-Johnson, if there's a lot of skin breakdown, especially in the context of mucositis where the child cannot replace the fluid, the child cannot drink enough, then dehydration is the thing that can kill them. So the key about Stevens-Johnson's management involves supportive management, mainly around maintaining the right amount of hydration replacement that you need to give. So it is a dangerous condition and it is an emergency. You have to work out how much fluid the child's lost and try to prevent that. And the complication or difficulty is Stevens-Johnson syndrome is they're very, very irritable because they're in a lot of pain because of skin damage and breakdown. So sometimes to comfort them, to insert a branula can be very, very tricky. At the same time, you want to save the life by giving fluids, intravenously. However, the child might be more irritable and might be more, fretful of you. So you kind of have to approach it in a very, relaxed way. So with that in mind, what do you think the management should be apart from maintaining hydration? Does anyone know?
For Stevens-Johnson's, doctor,
Yeah.
I think we have to remove the cause of the Stevens-Johnson's, which might have been the antibiotic given earlier. So stop that, and then since the patient is usually in pain, then I think we can consider giving painkillers to the child.
Yep.
And
so what painkillers do you think is appropriate
for children? Okay, I'm not sure about this one. Is Panadol okay for them? Or NSAID?
Panadol, paracetamol, I think is a good start. Yeah.
Mm-hmm.
Do you need to convince or somehow manage, for them to take it orally, which can be difficult in Stevens-Johnson's because it is very painful for them to swallow, unless perhaps you want to insert an NG tube, a rice tube, and give the medication that way. That's one possibility. Yeah. So in your pain ladder approach, always start with the simplest analgesics first, like paracetamol, before you move on to the next stage. But sometimes paracetamol might not be enough or adequate because the pain is so difficult to bear. So to the point, morphine can also be used in circumstances where you really want to make the child to be comfortable and so that the child has a decent sleep, decent rest, because bed rest is another important aspect of the management. Okay, anything else?
For the skin, we can apply topical corticosteroids, I think, to reduce the inflammation, or moisturizers, or a cold compress.
Yeah, so this is a bit tricky because it can be very, very sore. The skin will be very, very sore and painful. The last thing they probably want you to do is to put things like creams and cold compression on it. So most of the time we try to avoid that. But steroids has its role. And so Stevens-Johnson is actually associated with immune complexes that's attacking the skin and the mucosa. Yeah. And how to prevent the immune complexes from happening is you want to give steroids to reduce the reaction of the body towards the skin and mucous membranes. So sometimes we do use IV methylprednisolone just for that purpose. Yeah. So that's one thing. You mentioned we should treat the cause, which is the Mycoplasma. So what antibiotics we use for Mycoplasma?
Okay. I'm not sure anyone can help me. Mycoplasma.
So Mycoplasma is a atypical infection. What's the antibiotic of choice for most atypical organisms?
For a typical, suitable if we give macrolides such as erythromycin or azithromycin.
Yeah. So macrolide is useful. So either erythro or azithromycin. If you ask me, we always prefer azithromycin because it's just a once daily dosing antibiotic compared to erythromycin, which is 4 times a day. So azithromycin is a very useful drug to give to stop the infection from causing further problems. Okay.
Can I ask?
Yes.
Regarding the management of Steven Johnson, previously said about the role of giving IV methylpenicillin. And also there is another adjunct therapies like IVIG and cyclosporin.
Correct.
Actually affect this organ.
Yes, correct. So that's the next stage for severe Stevens-Johnson syndrome. If you cannot control with just supportive measurement, the majority of Stevens-Johnson's are mild to moderate. Supportive therapy is all you need to give. You probably don't need to give steroids. I mean, let the skin rest, it will recover. In severe Stevens-Johnson, that's completely widespread, and you're concerned about, widespread skin damage and mucosal involvement. And you worry about secondary infection. It's very common, and in Stevens-Johnson you get cellulitis, sepsis. So it makes sense to treat it a little bit more aggressively with IV methylpred, and if that doesn't work, IVIG. Yeah, so I agree. IVIG and things like methotrexate or tacrolimus are further drugs to consider to prevent further inflammatory cascade from continuing and causing further breakdown. Yeah, so this is where we do reserve the use in very severe cases sometimes. I agree with that. What is IVIG?
Intravenous immunoglobulin.
Yeah. So how does it work, you think?
It will give more because it was a cutaneous reactions towards. So it give to help the reactivity towards the infection or certain cytokines.
Yeah. So you all heard of the cytokine storm, during this COVID-19 era. So cytokine storm is the thing that will kill patients with COVID-19, similar to SJS. You get these immune complexes that will release cytokines as a response, and it's the cytokines that's kind of causing problems rather than just killing the organism, which is Mycoplasma in this sense. It kind of causes damage to other parts of the body. And by giving immunoglobulins, you reduce the chance of the cytokine storm from continuing it's kind of a process. So you give immunoglobulins, which is a kind of blood product. It's a mixture of immunoglobulins. It can be either recombinant, like DNA engineered product, or it can be a form of pool of donors, and you want to give it to reduce the body from thinking that they need to produce more immunoglobulins to produce infection, because the more immunoglobulins they produce, the more immune complexes that will be formed, and you get more cytokine storms. So the idea of replacing a little bit of immunoglobulin is to prevent the body from overreacting. Yeah, so that's a useful adjunct to use in severe cases. Okay.
Doctor, I want to ask another questions. When we should refer to dermatologist or ophthalmologist for this case?
Yeah, so When to refer depends on the degree of severity. In mild to moderate, maybe a general pediatrician in the general peds ward would be able to manage. But at a moment of time, if you think this is severe and you're thinking about IVIG and IV methalpred, normally they have to be somewhere in ICU setting, because you never know that the child might deteriorate and get a full-blown sepsis as a complication. So it's better to be monitored in ICU setting, and ideally with a place that has rheumatology input. But in context of our country, that doesn't have to be the case. You can just admit in ICU and just discuss, over the phone with any rheumatologist about management, because most of the time all the adjuncts should be available in most of the hospitals. Yeah, at least the main one. Things like tacrolimus are available. IVIG should be made available. But other complications such as eye problems, one of the complications of SJS, it can cause you severe uveitis, and that can lead to blindness. So if you're concerned, I think it's good practice to always refer to ophthalmology to check the eyes anyway. So depending on the problem, the intervention will be decided by the ophthalmologist in charge. And the other thing you need to worry about is the sepsis you need to cover with stronger, more broad-spectrum antibiotics. So most of the time, the general physician should be able to manage SJS that is not too complicated. Yeah. Okay, good. Any questions?
Doctor, in child with Steven Johnson, do we usually need to give nutrition supplementation?
Yeah, it's very common while you wait for the mucosa to improve, and that can take days and weeks sometimes. So you want to ensure, quite rightly, part of the supportive treatment is to provide enough nutrition. With the mucosal involvement, that can be tricky because the child might not want to tolerate eating and drinking. So it's enough to perhaps consider NG feeding. Very rarely we use TPN. I don't think we use TPN unless in the context of ICU, if they're intubated and you want to fast them, you want them to be nailed by mouth, then maybe you consider TPN. But if they're alert, if there's no complications that are severe, you can start on rice tube feeding, just to ensure that nutrition is adequate. The other thing I forgot to mention is one other things you can give is mouthwash, like local anesthetic mouthwash, to give them comfort. And this things like ginger gel and also what's it called? Deflam. So Deflam sprays, you can use that just for relief as part of your simple analgesics strategy as well. And so mouthwash is kind of useful. But the key thing is to prevent infection. So the skin, you need to make sure the skin is always clean. Any pus or slough that you can see can be a risk factor for infection. So skin therapy, making sure that the hygiene is good, skin hygiene is good, is always important, because most of the time sepsis occurs from wound infection, from all the skin breakdown. So I cannot emphasize that anymore. It's hugely important that you keep the skin hygiene very important, and that can be difficult in a child who sometimes doesn't want to move, and we want the skin to clean their back, for example, to make sure that there's no buildup of any slough and pus and all the debris from the wound. It can be difficult to kind of mobilize the child. So it is a bit tricky. It's not something that's very easy to nurse a child with Stevens-Johnson. So when I talk about ICU, sometimes if the Stevens-Johnson's is so severe that the child is in too much agony, sometimes we do intubate them and also make them sedated, just for the purpose of allowing the skin enough time to recover and to make sure the child can, kind of bear the pain. So we do that in severe cases. We do admit to ICU for intubation for the purpose of comfort. Yeah. So intubation, don't think of intubation just because you think of respiratory problems, sepsis, severe sepsis. Sometimes we do electively intubate where we want to sedate the child enough so that the child will be very comfortable until the condition improves. Sorry, any questions?
But I have one question.
Yep.
If the patient is admitted to general ward, is it necessary to isolate the patients to avoid hospital-acquired infection?
I think it's always useful. I mean, you don't really need to for strict isolation point of view, but if you have the capacity to use to isolate is better. But it depends on the bed capacity at that point, because Stevens-Johnson's is non-infectious, so you won't spread it to elsewhere. But I agree, to protect the child, maybe you want to limit exposure to other children. But as I said, the sepsis that occurs most of the time is secondary to lack of hygiene and also skin care and wound care. If a child next to him has pneumonia, it's very unlikely for the child to infect the other child with Stevens-Johnson's unless the other child comes very closely and had direct contact. So from that point of view, it's not strictly an infectious a disease that you need to limit the amount of exposure. But it's probably useful to isolate them. Most of the time we do isolate them to allow the child to be less irritable with what's going on around the ward. Because sometimes in an environment where it's too busy and the child's in pain, it will just aggravate the pain when the child is in a very hectic environment. So bed rest, plenty of rest is important for the child. And also for parents looking after the child. Okay?
Doctor?
Yeah.
I got one question. Okay.
Yeah.
In this case, how can we eventually differentiate that the patient has Stevens-Johnson syndrome secondary to Mycoplasma infection or due to the antibiotic that was given previously?
Yeah, I think it's very difficult to, as I said earlier, you cannot quite do a test to know which one is which, because it could be the antibiotics, it could be the Mycoplasma. It's in a sense, sometimes if we think it's the antibiotic that's related, we do stop the antibiotic, depending on what antibiotic it was, and change it to something a bit more broad spectrum. Unless once you do your tests and you find no signs of infection whatsoever, the CRP is not high, yes, I know, ASOT is negative, Mycoplasma negative, all your virology test is negative, then maybe you don't need to cover with antibiotics anymore. But sometimes you do have to balance the, between not treating the initial cause, which is in this case the Mycoplasma, because it's something you cannot ignore. So I think if it's positive, you have to treat it, because that's the only proof that you have that this could be the trigger. You cannot prove the antibiotic is a trigger because there's no test that we can do to show that causal relationship. But I think you cannot ignore the Mycoplasma. In this context, hence, I would err on the side of treating it. Perhaps with antibiotics that are different to the one that has been used before. Yeah, I think that's a very useful, good question, but it can be a bit difficult to really know which is the actual trigger in this case.
Okay, thank you, Doctor.
Yeah. Okay. Good. Okay. What do you think about the question? Is this a difficult question, do you think, for PMP in Year 5?
Just nice.
Just nice.
Surprising.
Surprisingly easy.
No.
No, surprisingly okay.
Surprisingly okay, yeah. I think, as I said, I mean, we don't really. I mean, getting the exact diagnosis is only one mark of all the marks that you can get. So don't be too hang up by getting the right diagnosis, although it will be helpful if you do get it. But the early part of the triggers is all about knowing your thought process of trying to come up with a differential, and then thinking about your investigations and what appropriate investigations you want to perform. And obviously, trigger T will be about your management plan. And that's when getting the right donors is helpful. But I think most of the management is correct for anything like in supported treatment, bed rest, maintain adequate hydration, analgesics, plus or minus antibiotics, and so I think you won't go far off with that. Yeah. Okay, is that okay? Any questions before we move on to the next session? Okay, is that okay?
No.
Afika has left, isn't it? Has she come back in? Oh, she's back.
Just presenting.
Say again?
She's here.
Oh, please. I see. Okay, fine. Okay, good. Now the next part is where I did ask you earlier about giving me a number. So what I have in my hands is a series of cards with cases on it. Okay, just a brief description of a case. I don't think you can see, but I'll read it out one by one, depending on the number that you choose. I don't think I'll have time to go through everyone today, so we might choose at least 4 or 5 cases. And this is kind of like your MCQ or OBA kind of exercise, yeah? So we want to know what's your thought process is like. So this is we're not trying to get you to explain everything, but I think it's useful. I have 200 cards like this. Yeah, flashcards, so quite a lot. So certainly some of these are useful from an undergraduate level, but bear in mind there are some of them are even difficult for me because they can be a bit more kind of towards the postgraduate level. But that's okay. I think we can kind of go through. So who wants to volunteer? Let me see what the numbers are. Should we start off with Nadira? Nadira's here?
Yes, I'm here.
Ashley, Nadira. Okay. Right. Let me check. What number did you choose?
I choose 26.
26, yeah?
Yes.
Okay, this is a very straightforward, I think, case. Okay, I'll read it out, yeah, because I don't think you'll be able to see it on your screen. A 3-year-old girl is brought in after 2 days of non-bilious vomiting, which is improving, and about 6 hours of watery, non-bloody diarrhea. Her 5-year-old brother had similar symptoms last week and still having diarrhea. What is the most likely diagnosis? Ni atau year 3 boleh jawab ni.
Acute gastroenteritis.
Yeah, okay, so it's acute gastroenteritis. Why do you say it's acute gastroenteritis?
Because the siblings manifest, first the sibling manifest the same symptom as maybe due to contaminated food or water.
Yeah.
And then the symptom itself, vomiting and diarrhea.
Yeah. Okay, so there's a sick contact here, history of vomiting and diarrhea, it's non-bloody. What gastroenteritis in particular you think this could be? What could be the cause of the gastroenteritis?
Can be secondary to salmonella.
Salmonella, okay. Why do you say salmonella first rather than more common causes of gastroenteritis in children?
Because they commonly present in egg, contaminated egg.
Contaminated
I'm not sure
eggs.
that.
So you think they could have shared some eggs, contaminated eggs together?
Yeah.
Yeah, the sister and the brother. Okay. What's the thing about salmonella? Infection when it comes to the diarrhea symptom. That would that's different to perhaps a non-bacterial infection.
Um,
So if it's salmonella is a bacterial infection, kan?
yes.
So what about the diarrhea that is different compared to non-bacterial gastroenteritis?
Maybe it's also will have a fever, associated symptom of fever if it
Yeah,
is.
so the fever might be high grade, yeah, compared to maybe low grade fever for viral gastroenteritis. Anything else?
Uh, I'm not sure.
So diarrhea typically in bacterial AGE is tend to be bloody, isn't it? Yeah, so they think of bloody diarrhea like dysentery type, yeah. And dysentery its own is not infectious. I mean, you don't tend to spread so salmonella directly to another person unless that person comes into contact of your feces directly. Yeah. Um, so it's not as easily as spread compared to your viral AGE. And the thing about salmonella as well, if you, however, do eat from the same contaminated source of food, then yeah, you can get symptoms together. So that's also possible. Yeah. Okay. So the fact that this is a non-bloody diarrhea, had a brother who had similar symptoms last week, suggests the easiness of transmissibility, points towards what type of gastroenteritis you think?
Viral gastroenteritis.
Viral gastroenteritis, yeah. So viral, you won't go any wrong by saying viral gastroenteritis as your top cause for any gastroenteritis in children because that's by far the most common. Rotavirus, enterovirus, things like that is by far the most common. So I wouldn't say salmonella straight away because it's not as common. Okay, good.
Okay.
Fine. So who wants to let's see siapa yang kita tengok siapa yang kena. So next stop is the Dua. Is that right? Have I pronounced your name correctly?
Dua, yes.
Okay. Now you chose 147. Now you'll probably come to know that in life, the earliest numbers tend to be far easier. And it gets much more difficult the bigger the number. Anyway, that's okay. So let's go through this. I'll read it up to you. Yeah. Okay. So an infant's newborn screening is positive for PKU, phenylketonuria. Have you heard of this before?
I'm afraid to say it.
PKU, phenylketonuria. So some countries they do screening for metabolic disease, including PKU. In Malaysia, we don't have that. We only screen for thyroid and also for G6PD. Okay, PKU is one of those metabolic condition. So the question is here, what is the treatment of this disorder? Have you heard of this condition before?
No, I think the last time I heard about it was in year 1.
Yes, exactly. I think last time I heard of it was when I was a medical student too. So it's not very common. But okay, so in pediatrics, sometimes the cases that you see, obviously, the rare ones are not common, and we don't expect you to come across them directly. Things like PKU, things like like earlier in my group discussion this morning, we had a case about hemolytic uremic syndrome. These are all rare cases, but sometimes we do come across this a lot in medical textbooks because it's so common in the pediatric population because it's not something you come across in adult. Yeah, things like cystic fibrosis is maybe if you go to HTA, you might not come across any of children with cystic fibrosis. Some of you might be lucky seeing one or two. So it's that kind of commonality of this disease. But if you open any pediatric textbook, if you open the respiratory chapter, cystic fibrosis will be in there. It will be explained in good detail, and similar to certain metabolic disease. So I think, while this is a very tough question, but maybe have a guess. What kind of disorder this is?
It has to do with the amino acids because it's phenol.
Yes.
So
phenylalanine. Yeah.
Yeah. So I think we would have to control their diet.
Correct.
Reduce phenylalanine.
Correct. Yeah. So it's not that difficult, isn't it? So when you think about metabolic disease, most of the time it's a defect of something. They lack certain enzymes to digest certain food or products. So in the context of phenylketonuria, they don't have enough enzyme to digest phenylalanine or to absorb phenylalanine. So phenylalanine gets built up in your body. Anything that doesn't get absorbed and any amino acid that is floating easily in the body can become problematic. So what kind of, like any metabolic condition, yeah, what kind of problem do you expect to see in a child with excessive amino acid floating around the body? What kind of, just give a guess. Yeah. Do you understand the question?
Sorry, I was muted.
Yeah, so what kind of symptoms do you expect to see in a child with excessive phenylalanine in the body, like you would with any metabolic disease? If you have excessive amino acid or organic acid, what will happen to your body? What will happen to your child?
I think in children, we would have to watch for a kidney disease, and maybe they'll present with seizures.
Seizures, certainly, yeah. So you have too much amino acid, your body becomes acidic. Too acidic, you get seizures, and you get disruption of your electrolyte, of your acid-base balance in your body. Yeah, okay. So seizures, what else?
What else?
Yeah, what else? What other symptoms you might expect to see, you think, in a child with too much amino acid in the body? Seizures. What if the amino acid deposits occurs in the brain, mainly? So what would happen to the child?
Developmental delays.
Yeah, so developmental delay is very common in any metabolic disease, just be in view of extra deposits in the brain that can cause delay in acquiring the right motor skills. So sometimes you can actually figure out by guessing what the anticipated problem might be. Yeah, but you quite rightly mentioned the treatment is to avoid phenylalanine. So you might want to kind of restrict your diet. You look up on the ingredients of food that contains phenylalanine and just reduce the amount of intake of those. So unfortunately, there's no drug or medicine that you can give. It's just mainly around preventive medicine. Now, the key thing is, what do you think the prognosis is of PKU? What's the prognosis? Good, bad?
I think the prognosis would be good if the diet properly restricted.
Yeah.
But if you mentioned that they don't get screening very well here in like Malaysia and probably my country as well, then it would have bad prognosis because they would be presenting with developmental and possibly retardation.
So you're spot on. As you rightly said, it depends on the timing of the diagnosis. If you be able to identify earlier of all these metabolic conditions, the quicker you can start treatment or perhaps prevent damage from occurring to begin with, for example, by dietary modification, then the prognosis is favorable. So in other words, in the context of those who are diagnosed during the newborn period, straight away, you will be, because we don't expect the child to start eating and drinking in the first few months, only milk, isn't it? So milk, especially breastfeeding, doesn't have phenylalanine, isn't it? Unless the mom takes it excessively. So the earlier the diagnosis, you can control the damage from occurring. Hence, the child might end up becoming a well thrived person with full mental capacity and so on. So this is where, in one angle, newborn screening plays a very, very important role. It's a bit unfortunate that we're in the year 2020, but our country is still quite lacking in terms of expanding the newborn screening. So we're still stuck with G6PD and thyroid function tests. For example, in the UK, we test roughly about up to 12 or 13 conditions. In some countries, like in certain parts of the United States, they do check up to 20 or 30 conditions. But you have to be realistic in terms of how common do you think the disease is among the community. Yes, like for example, G6PD is very common in the Southeast region. So that's why we do screening here. So, and that's why it's not adopted in Western countries, because G6PD is not as common on that side of the world. So you do have to look at the context of the epidemiology of the disease, whether it's, if it's really, whether the incidence and prevalence is high enough for you to seek to prevent it from not being screened. Do you get what I mean?
Yes.
Okay, good. Right, any questions about that?
Thank you.
All right, good. That was good.
It's not so common.
Yes.
Here.
I don't think it's as common, yeah. So it is autosomal dominant. So perhaps it's screened quite early, and even even if you do have a family history, there's always a 50% chance you might not get it. So even without family history, the chance of you getting it is very minimal. Sporadic mutations do occur, but normally most of the time there is a family history, so you shouldn't miss it really. But I've not come across one so far being in Malaysia. So I don't think it's as common. But other metabolic conditions we do see. Cytokine is just one of many conditions that can occur. Okay. Right. So with that, in terms of rare conditions, yeah, we don't tend to ask it too much in PMP or in your written examination. But when it comes to MCQ or BA, that's when we sometimes include it in there. So sometimes you do need to have some degree of knowledge, but you can also somehow think it logically as well. Okay, next one is Afika. Afika. Okay, Afika, you choose 28, eh?
Yes, doctor.
Okay, this is a bit tricky even for me. And some of you even might think this is more gynae problem. Should we just give it a try? A 15-year-old girl, 15 you all done gynae before?
Last in year 3.
Yes, year 3.
Year 3. Oh, okay. Okay, let's see. Let's see. Because last time I did it when I was in houseman. So let's try. A 15-year-old girl presents with gray vaginal discharge with her menses. A positive fishy odor with KOH test. This is the potassium hydroxychloride test, isn't it? And many clue cells are seen under the microscope. What is your diagnosis?
Sorry, doctor. What cell?
Okay, a 15-year-old girl present with gray vaginal discharge with her menses, positive fishy odor with KOH tests, and clue cells are seen underneath the microscope. What is your diagnosis? I think if I remember, my memory serves me right, there are a few words here that will make you think of this condition in particular. I don't think this is pediatrics at all. But in Malaysia, it's different because we don't see 15-year-old in our clinic. But in some countries, pediatrics is up to 16 years old. So that's why they've included in this series of flashcards. What's your differential diagnosis? Fishy odor, vaginal discharge, clue cells.
Is it vaginal candidiasis?
Not quite. You basically, the KOH is you put down 10% potassium chloride, and normally you get this fishy odor when you put the potassium chloride in there. Anyone?
I don't know, doctor.
Anyone wants to be a gynecologist?
Doctor, what about bacterial vaginosis?
Yeah, correct. So that's so why do you say it's vaginosis?
Because there's a gray vaginal discharge with the menses.
Yeah.
So sorry, I googled the clue cell is from Gardnerella vaginale. So
Yeah,
that's why.
good. Yeah, so you use your technology that's in front of you, Google it. Yeah, so I think doctors, not all of them is in our memories, in our memory cells in our brain. Yeah, so sometimes we do have to Google it up. That's what I would do when I don't know things. So yeah, you're right. So this is vaginosis. Typical wording here is the fishy odor, and also the clue cells, and also the gray discharge. And these are, typical of bacterial vaginosis. I'm not a ONG specialist myself, so don't ask me further about it. That's all I remember from my medical student days. Treatment. What's the treatment for vaginosis? If you can remember in year 3, did you come across this in year 3?
Usually candidiasis, but candidiasis, I think there's the suppository, you put it in the vagina. I'm not sure if it's the same with bacterial vaginosis. Is it?
Yeah, okay. So you give antibiotics since it is an infection in the end, isn't it? So so you give metronidazole. Yeah, so metronidazole because it's anaerobic infection. Okay, I think we'll skip that because I think it's not too pediatric related. So next one is Asrar. Asrar is here?
Yes.
Okay, this is another tricky one. Okay, you ready? So we have a mother. A mother comes to see a 4-month-old boy. a mother with her 4-month-old boy come to see you. She's concerned that the back of his head is flat, lepe, okay? The back of his head is flat. She reports him, she puts him back to sleep, as you would expect, for a child. Rather than sleeping prone, she puts the baby on her back when he sleeps. So the question is here is, what do you think the diagnosis is, and whether you want to be concerned about it or not? You want me to read it again?
Yes.
Okay, a 4-month-old boy. The mom is concerned that the back of his head is flat. And so probably referring to the skull, perhaps. So she's concerned about it. Okay. So the question is, what is the possible? And when the child is sleeping, the mom would put the child on his back. Yeah. So rather than on prone, which is lying on the tummy, the child will lie on the back when the child sleeps, when the baby sleeps. So would you be concerned about it or not?
Maybe the changes in the head maybe due to the position of the baby to sleep. So it is one sort of positional abnormality.
Yes, it could be.
So
do you know of any name, any particular medical term you would use?
Not sure. Can I Google it?
Yeah. Of course. Yes. Tell us.
Brachycephaly.
Say again.
Brachycephaly.
Brachy.
Yes.
Okay. So brachycephaly normally means, if I'm not mistaken, it means brachycephaly. Yeah. I thought brachycephaly means abnormal shape. What does it say on Google? Brachycephaly?
Brachycephaly, or what we call as plagiocephaly.
Plagiocephaly, yeah. So that plagiocephaly is a term that I was looking for.
Okay.
Yeah, I mean, brachycephaly is not something that I will come across a lot, actually. Google says something about dogs and cat breeds here. So it's probably related to other species. So yeah, plagiocephaly is the word that I'm looking for. Plagiocephaly means abnormal shape. Okay, so you can have many types of plagiocephaly. You can have it's kind of the horizontal plagiocephaly, where your head is elongated. You can also have kind of sagittal plagiocephaly, where it's lebar, so it's kind of wide rather than elongated. So the nature of the plagiocephaly can differ. It can be positional, as you mentioned. Positional means that if the child enjoys lying on one particular side of the head, like the child every time lie down like to face on the right all the time, for example, and this can be behavioral, or you also have to exclude as well. Could there be problems with the sternocleidomastoid? Is, for example, if one of the on the side that's kind of pointing towards where the child faces, yeah, on the ipsilateral side, where there is contracting too much. So there's a condition called sternocleidomastoid tumor, where you get overcontraction of the muscles, and that can cause positional plagiocephaly. But sometimes positional plagiocephaly can just be behavioral, so it's just a preference of the baby facing to one particular side, and that can lead to one side of the head, one unilateral side of the head, to be flatter than compared to the other side. Normally, if that occurs, there will be some degree of compensation because the skull will try to maintain a kind of a circular shape, yeah, like a oval shape. That's a typical shape of the head, isn't it? So if one side is flat, then you might see that the opposite side. Thinking. I need to really draw this really to make it clear. But think of it as looking from the top of the child, from the top of the skull. Nice oval shaped skull. Yeah. So if one side is flat, there's normally a compensation on the opposite end of the other side. So that opposite end will become, more prominent. Yeah. So for example, if you have your left posterior skull flat, left posterior skull is flat, the compensation will be your right frontal prominence. Okay. So this is plagiocephaly. This is positional plagiocephaly. Now, if you don't see the compensation, so one side is flat, and the other, you don't see this any prominence involving the front head, then you would think about a condition called cranial synostosis. Cranial synostosis means early fusion of the skull. And so when you have early fusion of the skull, then you might cause you might have problems where the child cannot expand the brain properly, and you get developmental delay and so on. Yeah, so this is a bit tricky because to explain it without actually seeing it, okay, is a bit difficult. But if you read up plagiocephaly and look up what is positional and what is pathological, then you'll probably understand what I'm trying to say. Majority of plagiocephaly are positional. They're harmless. They will get better in time as the child sits up and no longer lies down most of the time. Then the skull will reshape itself normally. Yeah, so it's not something that often needs to be concerned about. You do need to check that the development of the child is normal. You do need to check that the size of the head is not abnormally enlarged, for example, with hydrocephalus, or whether it's too small in the context of microcephaly. Okay, so I think that's a bit tricky and tough one, but I hope you can appreciate what I was trying to explain. But do please read out. Any questions about that one?
No, Doctor.
No? Okay. The other aspect we tend to see is regarding the sutures. So in cranial synostosis, we have early fusion of the sutures. Sometimes you cannot appreciate the sutures because it's all like a one nice plate of bone. Okay, so in newborns or infants, you should be able to work out the coronal sutures, sagittal sutures, distinctly when you examine the head. Yeah, okay. Right. Should we do one more?
Okay,
Now let's see. Who have I got here? Dahia. Okay. So, right. Okay. So your case, let me find. Okay, your case is a 12-year-old girl who developed a cold about 2 weeks ago. 1 week ago, her symptoms started to improve slightly. However, last few days it's worsened again. Okay, so she had a cold 2 weeks ago, got better, and then has got worse. She is now complaining of significant nasal congestion and headache. She has not been taking any medication so far. What do you think could be the problem? Okay, 12-year-old girl who developed a cold-like illness 2 weeks ago, improved, and then got worse over the last few days. She's now suffering from significant nasal congestion and also from headache. So what potentially could be our diagnosis here?
Okay, let me try that first.
Yep.
So, I think it's more about NT-related diseases. Is it?
More about what? Sorry.
ENT-related diagnosis.
ENT, yeah, certainly it sounds like ENT. Yeah, so you got your systems kind of right there. So what do you think could be the problem?
Can be chronic otitis media. No. Acute separated otitis media.
Otitis media. So you think it could be more ear infection kind of problem?
I think a blockage of the it can be a sinusitis first.
Sinusitis? Yeah. What are the risk factors here for sinusitis, you think?
Risk factor?
Do you have any risk factor here? Having the?
Because he has history of cold.
History of cold, yeah. Yeah, so I agree. So whenever you do have a cold, then obviously one of the complications in the recovery process of from that cold illness is you can get nasal congestion, nasal block, nasal accumulation, mucus accumulation, and that might lead to sinusitis, isn't it? Especially if your sinuses are full of mucus that are blocked, that can be a point of infection to be introduced. So sinusitis would be what other symptoms do you get with sinusitis?
Sorry, doctor, can you repeat?
What are the symptoms?
Quite looking here.
So what are the symptoms can you expect to see in a patient with sinusitis?
Okay, there will be also any feel painful at the eyes, around the nose area and the forehead, and also the headache, like in the chief complaint before. And for the nasal blockage, it can cause every reduced sensation. Smell.
Yes. Yeah, good. So you get kind of a pain all over your facial and the head region, isn't it? Mainly retroorbital. You got pain behind the eyes, pain around your cheeks, and also you can also get temporal pain as well. So these are all related to which sinuses are affected. So pain is the hallmark. And sometimes they can present with only frontal headaches, and people might over investigate by doing CT scan and whatnot to check for things like meningitis and encephalitis. What is the test investigation of choice when it comes to sinusitis? What is there any test that we can offer?
Yes, we have. Is it examination or doing? endoscopy like that?
Nasal endoscopy?
Nasal endoscopy?
Yeah, so nasal endoscopy might.
Doktor tak ada on phone kot.
Kalau on phone dia akan out left. Tapi doktor tak ada phone.